What's up, everybody? Welcome back to another episode of Nursing Uncharted, the podcast that delves into uncharted territory within your nursing practice. I'm Maggie Reichardt. I'm a full-time medical ICU nurse. I'm a mom. I'm pregnant with my second, and I'm your host for this podcast. Thanks so much for listening today. Welcome if you're new, and thank you for sticking by us if you're an NU veteran. This episode is sponsored by Amen Passport. Amen Passport is a travel app that helps you find, book, and manage assignments all from your phone, puts you in the fast track for your next travel assignment. So if you are in the market for a travel assignment, be sure to check that out. So this episode is chock full of vital information for all of us because all of us have to document. So I dare ask the question, how is your charting? Are you confident in your charting? Can you stand by your charting? Or are there a lot of holes? We're going to talk through what things serve and don't serve you in a courtroom in regards to nursing documentation and much, much more. And I think this is going to be a long episode because I have a lot of questions and we're going to get into a lot of stuff. So I think it's going to be really beneficial to you. So buckle up and thank you for listening. I'm sitting down with the GOAT when it comes to legal documentation. Her name is Maggie Ortiz. She also goes by Advocate Maggie MSN RN. She is a resilient and compassionate force in nursing advocacy. She's been a seasoned nurse for 23 years with a background as a legal nurse and a prior investigator for a board. Maggie's dedicated to empowering nurses to safeguard their professional licenses. So Maggie, welcome to the show.
Well, thank you, Maggie. Thank you for having me on, sister. Congrats on your little family. Love it.
Thank you. Yeah, it's the second time around has been a whirlwind.
Yes. Yeah, you're in the middle, I say, the hurricane, right? When you're a mom and stuff. So I've pivoted out, sister. My youngest is going to be 21. So I'm out here on the outside. So you're in the middle of the hurricane right now.
Yeah, trying to juggle it all. So... Well, tell me a little bit about your background and what landed you into getting into this field.
Sure. So I've been a nurse stated for 23 years, like yourself, spent 15 years in the ICU. So critical care background, level ones to, There's 2 beds here in the ICU. We got AFib RVR. And you're like, I'm really in the ICU, but I digress. Went on to do some emergency room, IR, cath lab, EP, endo. Went on, I had my associate's degree for 14 years. And then, I don't know if everyone knows, oftentimes as a nurse, you can be restricted from moving places if you don't have a bachelor's. So I was finding that I didn't know, I'd been nurse for 15 years, done surgery centers, freestanding agency. I was like, I want to do something different. And for about 5 seconds, I thought I wanted to be in leadership. So I did my bridge the ADN to master's in leadership. So I have a master's, but it's in leadership. It's not in, I'm not an APR and I don't hold, I'm not a nurse practitioner. And so I did procedural sedation. I was working IR, cath lab, endo, and seeing that we were being put into situations where it wasn't safe for an RN to be sedating because an ICU patient with an airway is a gift. You're not doing conscious sedation on that patient. That's a patient with an airway. That's not conscious sedation. And when you're asked to provide conscious sedation to a patient in a procedural area under the direction of a GI doctor, and no disrespect, but these aren't the people who can recognize rhythms or understand what's actually happening. And now you're giving high doses of benzos or narcotics, and this patient hasn't been screened appropriately. It's not safe. So a scheduler could use the tool that I created to say, hey, you know what, you need to be put on the anesthesia schedule to be worked up for an anesthesia evaluation. You are not RN sedate. So I did that in my master's degree. As we talked, you stated, I left the bedside because I wanted to do something different. Again, I went to the board of nursing while I'm working on my degrees. And I was trained as an investigator. So I went to national training with anyone, PT, OT, MD, even I say civilian or like people that we're going to go to like HHS or DHS, anyone learning the skill of an investigation. So I was there, national training with them. And then you go back to your respective board, you learn with an agency, and then I was taught how to use the rules and regulations, standard of practice, unprofessional conduct, and grounds for discipline in conjunction with the disciplinary matrix to look at the conduct. Are there violations? Yes or no? Come up with a chronology, a case review, And then that was the investigator. That was my job to do that. Call the nurse, subpoena stuff, under the executive director, right? But then I'm calling the CNO saying, I need Maggie's personal record. I need the medical record for this patient or whatever the conduct was, right? I was trained how to do, to subpoena those records and to have those sent over.
Okay.
And then I stayed for a short period of time, only 6 months, because what I now know and have connected with other people, there is a lack of due process under administrative law. Doesn't matter what license you hold, that they, in all, just kind of dumbing it down, what I've learned is that each state is allowed to make up their own rules and regulations under administrative law and hold themselves accountable. Right. So every board, right, nursing, physician, whoever, our representatives don't know what we do. Right.
Yeah.
So they're not the ones writing the rules and regulations. It's done under that regulatory board. Not all of them. Not all states have a traditional, what we consider a board, but there's some occupational law. There's some regulatory board that's given you the privilege. Whoever handed you your license at your state, that's who you're accountable to.
Okay.
So I do this, help nurses in their legal team primarily now full time. I left the bedside after COVID. I'm not going to bore you, and everyone here already knows why. Not a mystery. Yeah. So I'm just called to something different now. I'm called to, educate, make change. And like you said, charting, because, in all three courts of law, and I've been a civil expert as well as working within a board of nursing and then coming out and being also an administrative expert. I just told you what they subpoenaed, right? The medical record.
Yeah.
All three courts of law.
Yeah.
You know what's going to protect you? What you did or didn't document, and now you didn't document it.
Yeah, I feel like charting is one of those things, like, as nurses, we're responsible for so much, and every task gets thrown at us, and every task holds its own weight, and so we have to prioritize things, and, charting ends up being one of those things that we end up being lax about sometimes because, in reality, it's one of the biggest disservices that we can do because and not caring about our charting or not being intentional about what we're charting, so you better than anybody can talk about, like how important charting is and, thinking about charting from a legal perspective as opposed to just another task that needs to get done.
When you start writing down words, imagine someone worse than myself who will get on the stand and look at the jury, and you're at the CVS, that's your jury. Don't think that there's going to be someone who knows what you do that's called, and right, that's civil litigation, so it's medical malpractice, which will cross over to the board of nursing, but the board of nursing will hold you to a standard. You cannot say my job. They'll be like, okay, so I'm so sorry, you don't understand that you hold your own professional license, so now you're saying that you're an extension of who? You're not an MA, you're not a rad tech, so I'm so sorry, you don't understand. I'm sorry, did you want to go to 21711? And you're going to get smacked down. There's just no, I'm not telling you it's right. This is the stuff I've seen over the last decade that we're getting smacked down with. And then you don't have a defense. And then good luck in a civil case. Wow, that's theater. We've all seen some of the stuff. It's not really about the truth, right? Because some of the evidence isn't even admissible. And now go to the Walgreens. That's your jury who you're going to try to, and there's the wolf nurse who's going to be looking at the jury with a 20-page report with reports and the policy and all the stuff you did not do. And then you're going to be asked all that in your deposition.
Yeah. Right. Yeah. You have to answer to your charting. And we talked about this before, how the fact that, somebody at Walgreens is your jury. Like, I never think about charting in regards to layman terms because, if it's held up in court, I have to explain this to, a jury has to be able to understand it.
And some of it's not one of the things I teach in my course, number one, I start with is the basics, the chart. It doesn't belong to you. It doesn't belong to you. It doesn't even belong to the patient. That the data is theirs, but the organization legally by law has to maintain it in a certain, I'm not going to bore you with all those details. It is a form of communication between providers. It is not ours. Don't document like it's your journal. Don't do this stuff because then now who does the jury normally side with?
Yeah.
Not us. You harm the patient. They think that we're greedy, that all the words, right? And they're going to play that up. They're going to put your paycheck up there. First of all, they're going to make you talk about how great a nurse you are. Oh, let's talk about your education. And you've been a critical care nurse. You're going to dig your hole for the first 5 to 7 minutes, and they're going to be more than happy to see you do it.
I want to like set up this episode talking about, like court, like what court looks like, maybe the main reasons that nurses go, and then kind of go into like how we can avoid it.
Sure.
How we can, pearls of your wisdom on avoiding litigation. So like, what do you normally see? Like, what are the main reasons that we end up in court? What are the biggest things that end up being litigated?
So, I'm not a lawyer and I never give legal advice. And I always like to make that caveat. I do education, and just because of my background and as an expert. So as far as like civil cases, a lot of the most cases are pressure ulcers. They're falls that cause death or injury, any sentinel event, because that's low hanging fruit.
Yeah.
You know what I mean? And oftentimes there'll be a case, and so you'll be named as a respondent superior. That just means you work at the hospital. Everyone's name that was in the chart is in there, right? Because they have a case. They want money, right? So they put everyone's name, the dietary person who dropped off the food, right? Everyone's name is listed in there.
Yeah,
so it can be kind of scary. Once they start looking around, they're like, no, we're good. We're going to sign you a check. How much did you say you wanted? And so that never goes anywhere, right? It just, they scare you, tell you there's kind of a deposition, which you need to know about, but you also have rights. But then, it never goes anywhere. Or you get deposed, whether you're, so all civil litigation, like I'm suing you, there's medical malpractice, there's the patient complains they lost their leg, right? There was a balloon pump in, and unfortunately this is real, and the nurses kept documenting the loss of pulse in the foot for 6 repeated hours, and did nothing, right? So we go to deposition, but they wrote a check. Because again, how is that defendable? You documented repeatedly every 15 minutes that there was no pulse, right? This is an NCLEX question. And I'm not trying to hijack any nurse, right? But this nurse took on more responsibility than they should have been. This patient was a 1-to-1 and they were charged.
Yeah. Right.
The person lost their leg.
And in that, like, you need, like, because the whole, point of their case is that they're trying to prove negligence in some way. Gross negligence. Right. And so, making sure that you have that follow up on, what you did. You can't just be charting no pulse for every 15 minutes for 6 hours.
That becomes a code at that point, because you can't say the surgeon wasn't responding. They'll pull up an NCLEX question and say, there's your NCLEX question. That was one of the 5 Ps, right? Nurse, that's one of the 5 Ps that you had to learn. Do you want us to go into nursing education? Do you want us to go down that road with you? We're more than happy to in front of the jury. Absolutely. We'll go as far as you'd like us to. They're going to play you up as a dum-dum. Yeah. Right? And so now they just qualify everything you just said, right? And there's the NCLEX question, and you hold a professional license, right, nurse? So you're required to know that question, right? That's a medical emergency. So you told no one about it.
Right. And there is somebody in the courtroom. You mentioned a wolf nurse, like explain what a wolf nurse is, because this is the person that's going to be in the courtroom explaining things to the jury, correct?
Well, so the nurse who establishes the standard of care is the expert. Yeah. The expert nurse is the one. Now, may not necessarily be in the courtroom, because that nurse is getting paid $300 to $600 an hour. Okay. So may not be in the room. The attorney may ask her to come and sit in or him to sit in the courtroom while people are being deposed, or to come chime in, because again, a lot of stuff is Zoom, to be a part of the depositions, to listen to the depositions. But that nurse will be the expert nurse who has been identified, who says, this is an ICU case. I've been an ICU nurse in the last 5 years. More often than not, anyone that's willing to get on the stand is a nurse who's been about 15 to 20 years, right? They're very comfortable in their practice. Teachers, PhD, oftentimes these are the nurses that are experts, and they'll have science and data, right, all to back up the policy. They're allowed to have every policy that they ask for. Now, the other side will try to push back to it, but they'll have chain of command. They'll have all this stuff and written up a report and to establish with the jury, to show the jury, because it's not just me, Maggie, saying it. I have to show you based, yes, on my knowledge, but also with science. And I'm teaching the jury and the judge what the standard of care is. And
for
then,
that facility, for that specific hospital?
For the, not necessarily for that hospital, for that, like let's go back to the checking the pulse in the leg. That nurse is going to bring up all the research, because a nurse only can opine or give their opinion on another nurse. Physician only is allowed to speak on another physician. So the nurse's opinion will be based on, all the stuff that we know, Elsevier, Lippincott.
Okay.
We'll bring up science and just say,
standard nursing, evidence-based,
but have to dumb it down
from.
Right, for the jury and the judge to say, this is why we do it. A loss of pulse is a medical emergency. That's why their reports are sometimes 20, 30 pages long prior to getting to a deposition. The Wolf nurse has produced an in-depth report showing the deviation. That's why there's a case. There wouldn't be a case if there wasn't deviations. So there'll be a very lengthy report that
I see.
The judge and the jury will have tangible to review, with all the attachments in the exhibit or whatever she has from all that stuff, a policy. Highlighted, there's the deviations, this is what the nurse didn't do, right? It says right here, the nurse should have used the chain of command. And so that's her job. His job is to educate the judge and the jury, because they're lay people.
Right. Okay, gotcha. What's your opinion on, malpractice insurance?
Everyone should have it.
Everyone should have it?
Because think about, if you get fired from that organization, then who respondent superior does cover you under their malpractice. Everyone, PTO, anyone who works in the building, right? You have to be bonded. We're all covered under respondent superior. Now you get terminated right? Imagine, because every physician has their own lawyer, right? For a reason. Yeah. The facility has their own. Now you're the primary nurse and you caused, it could have been just a medication error, right? But it's because of you. And now who's cutting their checks? So if you're the primary nurse, you might want to have your own legal team. And do you have $20,000 to write for someone to come and represent you? So.
Oh, I didn't even think about the fact that, you could be terminated from, the situation that you're in. And
now you're standing in front of the board of nursing, and that malpractice insurance will get you an administrative lawyer as well. So it covers both. It will never cover a criminal. And this is what, $10, $15 a month, give up 2 Starbucks and there you are. I mean, you just call them like your home or car insurance. And I always tell nurses, start with your own car or home insurance, because you know what they want? Your money. They oftentimes underwrite and you don't even know. And you're going to get a discount because you already have my car and home policy with them. I'm a nurse. I work at the bedside in the ICU, right? You work in the ICU. This is what I do. And then they tell you, yep. And then we'll need $11 a month there, Maggie. Go ahead and send that on over.
Yeah, it ends up being, it's such an easy, it's just a couple clicks,
Yeah, and you can't wait. And nurses all the time, when they reach out to me, they're under investigation. And I'm like, well, so it doesn't work like that. They do have restrictions that you can't hit them up. And I don't know all the rules. I think it's within 3 or 6 months of retaining that policy. I think it's like a car accident as well. You can't get in a car accident and then be like, get the insurance. It doesn't work like that.
Okay, gotcha. Well, and maybe there's questions on the, are you currently being,
yes. You can't lie. Don't ever lie. Right. I tell nurses, please, that I was told when I was an investigator, go back to the time you're 18. So please don't lie on anything. Again, some of the stuff I talk about is not necessarily right, but you will be trolled in some states. So if you lie about something, again, now that's falsifying documentation. It's unprofessional conduct. Now they got to slap one more violation against you. I was taught to use microfiche.
Microfiche?
Yeah. Say that again. Exactly, Maggie. Exactly. Because I'm old and you're not. It's like looking under the microscope when you put that, when you used to go to the library, that's how it's taught to look you up, to see. Because again, if you're an older nurse, right, we were doing stuff differently. Like that's why I'm here, sister. That's why I'm here. Oh. Don't stand in front of a board, please.
So what kind of things can we be doing, day to day to avoid litigation in regards to our charting. What are like some of the biggest things that we need to be focusing on in our charting to avoid?
Please stop copying and pasting. That's never, ever, ever legal. Never, never. And I just read from a legal nurse who's an audit trail expert. And you know what she loves? That kind of stuff.
Yeah,
in
typos.
That's a gift.
Typos from 8 a.m. to 12 p.m.
Well,
to
or
4
that
p.m.
they've copied and pasted repeatedly. Physicians do it, nurses do it.
Yeah.
That's fraudulently documenting. And
I think about that in doc notes all the time. I'll read them and be like, this makes zero sense. You know, you're like, this is no longer the plan. You know, yeah, I know.
And now
because we don't think about
screen.
it.
Yep.
Yeah.
Now it's on a big screen. And now I want you to defend it. It's not a big deal until it is. So stop with the copy and paste. That shouldn't even be a feature allowed on any of these EMRs unless it's coming from a smart phrase, right? You have a smart phrase for pick line dressing change. You do the same thing. You look at the policy, and this is a gift. Follow that policy. I'm like writing it, my smart phrase, then I can adopt that to the patient that I'm caring for. But I'm not copying my assessment from 8 a.m. because it's the same at 10 a.m. No, you're not. Assessment unchanged. No. Or you document in the wrong patient's chart. You're not deleting that from anyone's chart. You're striking through it and you're writing a mistaken entry. That's the equivalent of ripping up a piece of paper. Would you ever rip up a physical medical record? No. Holy cow. You cannot delete. And we've normalized this too much in our world. And then you have sites that do it. They allow it. Your leaders will tell you to do it. And it's not defendable. This is a simple Google search. Law firms love when nurses do this or doctors do this. This is easily attainable through an audit trail. And she said, Epic, I read this, 3,600 options for capture, which a nurse doesn't understand. That's hijacking you every second. Every second in an audit trail, you delete something, you do something, or you're on a page and they're clocking you.
So if you like, let's say you document something wrong, you know, like what is the most appropriate way to correct that?
Mistaken entry.
Mistaken entry. Like, so
Don't write error.
Let's say like, you know, for example, like an IV we'll say was, you know, clean, dry and intact, whatever at 8 a.m. and then you check at noon and it's leaking. And like, you know, you put clean, dry and intact and you're like, actually, no, it was leaking at noon, like I should chart that. So how do you fix that?
So you already in the EMR, because again, this is a lot of drop down stuff, because more often than not, so you've already hit save and send that?
Yeah.
Okay, so that's done. So if you alter that, that would be the equivalent of you ripping up a piece of paper. Because imagine now you're coming back an hour or two later. Would you cross that out on a piece of paper, say, nah, that's not how, would you X through it? Or white out that or strike through it. Yeah. You could strike through it and just say, you know what, I mean, mistaken entry, you know, reassessment done, and then just clarify, you know, it was leaking, whatever it is you did at the time. You're not perfect.
Yeah.
Right? Don't hold yourself to the standard.
Yeah. I think it's just a matter of like being intentional about what you're charting and making sure that you're, you know, you have the time to like think about. I feel like there's so many times I'll be, you know, charting on one patient, you know, like doing my assessment, but I'm thinking about the other patient. And so then I'll be like, you know, thinking about my assessment of the other one while I'm charting the one for that's dangerous. Because then, you know, and then like I'll be charting like the respiratory assessment that I'm thinking about with the other one. And they're like, oh, wait, like I got to go back. You know, yeah, just like you have to like really spend the time and like catch yourself and make sure that you're writing everything correctly.
I tell nurses, try to do it in real time. Like in the charting class, I really like if you can pull the computer in there, if you can do anything in real time. I know it's time consuming. I know it is, but now I'm talking about your license. Does that get different? I mean,
even just the abnormal.
Oh
you know,
my God.
even the stuff that you just, you know, you're like, okay, this stuff I need to remember. Just put that in there. And then like everything else, like, you know, fill in the blanks later.
I agree. You got to make a note if there's a deviation. I mean, you got to who you talk to, because now you got busy and it's not documented, and now it's a year later. Do you remember? Go, tell me who that was. Stop. You know what I mean? Take the time. You know what I mean? Make sure that you're doing real-time documentation if at all possible.
What about care plans? Do you feel?
Oh God.
I know, because care plans are a mess, and like I understand why. They're like, the basics of our nursing care, right? They're supposed to like guide what we do, based on these different at-risk things, but like nobody reads them, and they're like a drop-down thing. They're never individualized. And like, I look at these care plans and I'm like, this is, it says like smoking cessation, like discuss with the patient about smoking. They're intubated. Like, I'm not doing this, but like, it's just so many, like, if you don't do that, it's just this long document that nobody reads, but then that's your name underneath this note.
And there it goes.
So like you have to know, like it'll be under GI, be like, ensure NG tube is in the right place. Ensure the PEG tube is in the right place. And you just like click both of them. Like, do they have both? No. It just like, it's such a ridiculous document. And I feel like it's one of my pet peeves, because I feel like Epic could, or whatever documentation EMR that you use, that's like a nursing informatics thing that I think that needs to be changed in our favor. Because
Did you hear that, world? Did you hear that? We need some help out here, nurses.
Yeah, right. Nursing informatics. Come on. Epic teams. But because
that is a newer discipline, actually. If you think about in the big world of nursing, I mean, because it is an advanced degree, and honestly, there wasn't that many advanced degrees at a certain time. So that is a newer discipline for us. And I think it's essential, and I'm not trying to disrespect any nurses, but I think that you should spend some time at the bedside before you go on to get this informatics degree, because you go straight through, and then, you know what I mean? They have no idea about what even like natural flow is and anything to work on. You got some smarticles, but you never touched anything. Yeah. Right. So you need to merge those two. Same, I feel like, with a nurse practitioner. You know what I mean? Yeah. You're going on and not touching a patient for at least 5 years, and you're getting this advanced degree. Part of the problem is you have nothing to draw from. Same with the nurse going to hospice or home health. What are you drawing from? Nothing. No. And that's where I see nurses getting in a lot of trouble, because they do stuff, and or you and I have seen sick patients. So I can look at someone, like you can look at someone and say, ooh, and I don't need to quantify with anything. This is not good. But someone who has nothing to draw from, you're in a home setting, you have no resources at all. And then I digress. And then they don't document, and then they don't call 911. But no, back to charting. It's huge. It is absolutely the care plan. I have seen charting, like you said, to nasal cannula. Like they've been off for like a week.
Yeah.
And I'm like, stop it. But it is the standard we're held to. We create nursing diagnoses that go along, the medical diagnoses. And when it's up on the big screen, you know what that wolf nurse is going to be opining about?
Yeah.
What's in our lane?
Or even like, in the care plan, a lot of times it's, the care plan is whatever just automatically comes up from the EMR. Like, if you chart on a Braden scale or something that they're at risk for skin integrity, then like that's the only thing that pulls through in the care plan. And so in your care plan, the only thing that you're looking at is skin integrity. Like you have to go through, be like, oh, they're here for pneumonia, they're intubated, like they have a respiratory issue. You have to chart on that. They're mechanically ventilated. That's also part of the care plan. Like you have to individualize it. It's not just skin. Like, it's just...
And part of this is that there should be like an admission nurse for that very reason. Because again, sometimes you're so caught up that you're just like, the smoking cessation, a lot of people don't realize that's tied to a core measure. And so, the hospital's not going to get paid. If they ding on this, right, vaccine, smoking cessation, these are all things that will get that as a core measure. And so if you don't meet that, then... But I tell nurses, this is what you're held to. That will be up on the big screen, and the other thing that I'm big on is stop documenting noncompliance. Don't even get out of the habit of using that word, because now it's on the big screen, and now I just brought up your nursing care plan. So you said they are noncompliant with their CPAP. So you talked to RT, right? So show me a note where you talked to RT. You called respiratory therapy down. What resources did you give them about masks, about, did you talk about like nasal prongs? Because we did a simple Google search in here. Did you talk to them about anything? You just called them non-compliant nurse? Don't do that. So I document all that stuff, and then you document, or I tell the nurses to document that patient made a personal choice. You see how that sounds less offensive, and people are allowed to make their own choices. And then all the education that you did is there, and then you write that the patient made a personal choice, not their way, their CPAP, reinforced education.
Yeah.
If you label them as non-compliant, they have a personal choice. So please stop documenting that.
I feel like that in itself is such an issue, that we forget that people have their own ability to make bad choices. That's just people, if they don't want to wear, if they're a COPD or in the ICU and their CO2 is 90 and they don't want to wear the CPAP, that is their choice, like that. It's just like, you can't, restrain somebody. I mean, you also can't wear BiPAP if, anybody's restrained, but like you can't force somebody to, do something that is if they don't want to do it. I mean, people have the choice to be.
But we're obligated, because we do have a duty, and that is a loaded word, to educate you, to give you some options.
Absolutely.
But after that, you are allowed. You talk to your doctor, and that's not on me. I educated you. I did my, you know what the possible outcomes in. I let your doctor know, hey, dude, he's not wearing a CPAP. Like I'm letting the doc know, because if I'm documenting that, I'm letting the physician know, and that's on him. And maybe it's not like I'm giving him a call, right? I mean, in rounds, I'm just saying as well, hey, he's not wearing a CPAP. We've educated him stuff. I just want you to know that. You know what I mean? And then in my note, I'm documenting that I let Dr. Smith know, not in an ugly manner. It doesn't have to look ugly, right? It doesn't have to be offensive. It is your duty to let the doctor know you're not managing that patient's care. You're part of the team, but the doctor is managing this patient's care, and you have a duty to let the doctor know that the patient is choosing not to wear their CPAP after you've done all your education.
Right. Yeah. I feel like we think that there is more of a risk of litigation if somebody, like Crohn's
makes a personal choice.
Yeah. And so that instead of, and then you have this like moral distress, when it's like eliminate that moral distress, do what you need to do, like educate the patient. And then if they make the decision to not do something, that's on them.
Right.
They're
competent. They've been found to be competent. The only time it becomes an issue is if they're not competent, they're a child. Minors, obviously, this is not applicable to, right? Someone who's not competent, that's not, true. We have to protect these people, but, we're not talking about these people. You document this, they choose not to do it, then that's not on you. So.
Have you ever encountered something where somebody's competency was taken away, like inappropriately?
From a nurse or a patient side?
From the patient, like from a patient side. Like if they were like non-compliant with something, or like they were just refusing to not do this like life-saving thing, and they're like, obviously they're, incompetent or something. Like has that ever
Yeah. I mean, I've worked at like level 1 trauma centers. Oftentimes you'll see that with the ethics committee gets involved.
Yeah.
Ethics gets involved, and we don't, right? Because we don't, that's something that's never taken lightly, and we never remove anyone's rights or allow them not to be competent. That's not a decision that any RN makes.
Right.
That's a physician provider. But yes, I have been involved where they have found the patient not competent or a risk to themselves, suicidal or homicidal, and then they don't, right, they're getting their rights taken away from them for whatever period of time.
Yeah.
So I've seen that a lot in the emergency room and in the ICU, where they have to emergently detain them. But I just went to a meeting, I don't know, like 3 or 4 months ago, where it was done by the lead counselor for Baylor, because there was some new litigation that was passed about emergently detaining people. And I mean, like, these people have rights, and as a nurse, you better make sure you know what that means. If you're working in an emergency room setting or an emergency room setting, and she was it was a CE, so I went to this to get a CE, because I'm very also about nurses, not just writing a check for some CEs. It's, try to get involved in stuff like this is very impertinent. Like, I was asking questions, like, I'm like, wait. You're saying the provider is supposed to inform. Please define provider, because it's not within my scope of practice to be telling the patient. So I want to clarify that and make sure that's clarified, and that a policy reflects that within the organization, because the nurse shouldn't be held accountable for what an MD should be explaining to the patient. No.
Yes. Yeah, absolutely. What about, I know we had talked about this in a previous conversation about starting education of these types of like documentation practices in nursing school. Yes. You know, like we were talking about how, you know, if you jump into, you know, some of these like outpatient, like remote positions that require like a lot of experience and stuff, that because you need that like, you know, groundwork. Otherwise you know, going into those things blind. I think like one of the ways that kind of tied into me a little bit for, you know, setting up these things in nursing school and like getting some experience on like how to chart and like what is important to chart and why it's important, you know. That's
I agree. And I've reached out to instructors. I've had like nursing students will reach out to me, new grads will reach out to me because they're desperate for that kind of knowledge. Even when I talk about the soapy note, people are like, I've never seen this. I'm like, a soapy note? What? Yeah. What are you saying?
Yeah, I feel like they don't do, well, I think they do, it seems like they do them in different, you know, in a different format now.
Well, they're trying to discourage away from this. And let me just break it down for you, just so we all understand, because I'm 23 years in. When you're like 5 years in, you're drowning in medical terminology you cannot look up. You don't even know what's happening around you. You get 5 years out, you're looking around a little bit, you get a decade in and you're jaded. You're jaded up, right? I'm 20 years in, I have no illusion. When I walk into a facility, it is a business. Do not forget that. You are walking into the business of healthcare when you clock into your job. So why have they moved to EMRs? Cost capture. Don't kid yourself. Now, because they can capture anything. And I've worked in areas, like especially procedural areas, where we're told, because if I'm doing real-time documentation during a procedure, which does happen, let's just say in the cath lab, and I'm told, because I'm the one documenting in the control room, it's real-time documentation, he's capturing, he just shot dye to, you know, the renals. That's a cost capture, sister. Yeah. The next one, I just shot cores or coronaries, or that's a different cost capture, sister. Yeah. I mean, so you understand that a lot of things that they do and why they want you to check boxes, because they need to cost capture everything. It's not set up there for us, right? It's not set up there. It is efficient. It is more efficient, right? That's logical, right? You can click box. But then we get away from learning how to write a note. We get so reliant on these box checks, and there are good ones for like potassium's 2. And the patient's having an arrhythmia. That's a great template. I love it. I tell nurses to use it. Then you're not forgetting something, right? Yeah. Oh, yeah. This is what I did. This is the doctor I'm following up. Then I'm coming back to the template. But you still got to, like, something happens. You code the patient. You know, they go into an arrhythmia. Then that's not a Dropbox situation. Yeah, that's a note. And
code situations are documentation for codes is a mess. I don't know, like what is that like? Can you talk to that a little bit? Because I had to do code documentation recently. It was a 65-minute code. It was freaking long. And, you know, it ends up just being like time stamped, like every 2 minute, you know, you know, epi given, like CPR resumed, you know, shocked at 200 joules, like, you know, and it was like this long thing. I'm like, you know, this is what we did, you know, and I think, like I put like a little blurb about like how the patient presented, but you know, that's it. And they have in the EMR, they have this like flow sheet chart thing that you can use. And I think in order to do it in real time, but it's so complicated. And I'm like, I don't know. I just put in a note because I'm like, this is just, I don't know. Is this the entirety of what I should be charting, other than like, you know, scanning in meds and stuff, like after the fact, we scan everything in and, you know, document like everything in the MAR, like what we gave and stuff. But like, does that suffice?
Well, so let's unpack that. So I've also taught ACLS. So first and foremost, were you the primary nurse or were you running to the code? You're on the code team. What was your role?
I ran to the code. I was the scribe.
Okay. So just so again, never any judgment, right? When I talk about stuff, it's just in a factual manner. You have an ACLS card, correct? You took the
Yes.
education. You said, I know all of these roles and I'm willing to stand and do any of these roles when I respond to
Yeah.
a code. Okay.
Yeah.
So you come to the code and you choose, because you chose to be the scribe. Because at
Yeah.
that time, you have to say, if you don't feel competent, you need to say, I am not comfortable doing this in this role. So I tell
Right.
nurses that from foremost, because that is a legal piece of documentation that is protecting everyone that's there. So I
Yeah.
tell nurses, be very comfortable with that. When I teach ACLS, I'm like, if you want this printed out, we'll go talk to the educator, take it home. There's no patient information on it. So that you understand that this isn't, like you said, every 3-minute increment, and this will literally be on the big screen, and they will talk about this is your only role, yes or no. Yes, and it needs to be very, very, very detailed. And I tell nurses, because again, like you, I can't do it in the computer, stop it. Right, I'll get the downtime one off the crash cart, and that's what I use. And then I'm making sure that those boxes are checked, because I've seen it on the big screen, and this nurse was under it was actually risk management who came to give testimony, that because part of the code, the recorder was not check boxing that the patient was being bagged. Now, like I do, that was happening simultaneously, but it wasn't documented. So we talked about earlier, right, the gross negligence. You know how it becomes gross negligence? When they can show repeated conduct and violations. So you know why they highlighted that code sheet? Because it was just one more thing there's one more thing to add to the list of things that you clearly don't know how to do as a system, moved it into gross negligence. So
Okay.
make sure that you understand, like, okay, and my only job is I'm not taking any task. I'm the recorder. Stop. We're at 3 minutes. Are you giving epi? What are we doing? And then you do have to ask the uncomfortable things. I'll go over and grab your badge. Why are you doing? What's your name? Because I have to write your name on this, right? I got to know who's here, right? And then your only job is, right, if it's time for epi, why aren't we doing it? Are we shocking? Why aren't we doing it? And you need to make sure we're writing a little note. Who's running the code? So why aren't we shocking? Because that was a shockable rhythm. I need to write it down, because again, 3 years from now, we're not going to remember that. So what rhythm is it? We're following the algorithm. If there was a deviation from the algorithm, that needs to be make sure that that's written on there for whatever reason. The same one I'm referencing, they pulled Ramazicon. This patient was an MRI. They pulled Ramazicon, so you already know what was given, but never gave it. And then the primary nurse had been chasing his blood sugar, and Hispanic male. No one does a blood sugar. It's not documented anywhere on there. So, and not only that, if you pulled Ramazicon, I know I've given Ramazicon or seen it given once in my career. You know why? Because you will cause that patient to seize if you do not know their benzo history. So oftentimes you will never see it reversed or given. That will support someone's airway. We'll put in an ET tube and let you ride out that benzo, but we're not reversing that. Narcan all day long. Narcan all day long, but it's rare. The one and only time, and I begged anesthesia not to give it. They had nicked her artery. It was a neuro case, and I was like, "Dude, she's not respond." I wasn't even the primary nurse. I was helping out another nurse. I was like, "She's not responding. She is not responding, and her JP is pulsating." And I set up the stuff because we need to secure her airway. We need to get her to a level 1. It's not here. And anesthesia came over, and he was like, Ramazicon. I was like, dude, don't give her Ramazicon. No, Narcan, secure her airway. No. And he wanted it given, and she seized. And so, but digressing, going back to the code sheet, they pulled Ramazicon, but wrote no reason why they didn't give it. So you know what's questioned all through that case? So you charged the patient for Ramazicon, and you didn't give it. The one thing that could have maybe saved his life. No one knows that, but it's theater. I already told you it's theater. The one drug, the wonder drug that could have saved this person's life, and you pulled it and didn't give it, and you charged him for it. That doesn't look good. Doesn't look good. Doesn't look
They're
good.
painting a picture. They're making a case.
Those are the very words I use in my course as well. What will the picture be painted of the conduct that happened? Some of the stuff I'm telling you is not always right. So if you choose to be the recorder, just know that's a big job. It is a lot bigger than people really realize. And I'm not faulting anyone here, sister. You know I'm not. I just want you, when you choose to do that you understand. Not only that, not everyone involved is in litigation now. right? Because you said it was a code. So more likely, that's a higher percent that's going to go to litigation just by merely being a code, right? Think about that statistically. And now how many people stood there and we're all dependent on your documentation to protect us? To a certain degree. Now, the doctor's going to write his note, right? I respond to the code, my 30-minute critical, whatever it was. Right. The primary nurse should always be writing their own independent note as well.
Is it okay that because I was the scribe, so I put that in the chart as the scribe. It shouldn't, is that correct? Or should that be the primary nurse?
No, there should be more than one note. The primary nurse, she's probably writing something different. I called the code. She needs to say, I was doing all these things, and she really does need to say that. I recognized, I accelerated, quickly moved from a rapid or whatever, because that matters. Right, that recognized and got to a higher level of care. And sometimes as ICU nurses, and this is where I grew up, like, we don't call codes. Yeah, you do. I've seen people say that in a cath lab, and they perf the LAD, and we had no one else. And I said, I screamed, and I said, call code now. Call a code. That person would have died. Yeah. She lived because I acted immediately. And I'm not trying to toot my own horn, but if I had not called a code, we perfed her LAD, the Widowmaker.
Oh man. Yeah.
So don't get caught up in that stuff. I was like, I don't care. You call a rapid. If you're not sure, take shaming from your people all day long, and I will stand next to you. We don't shame one another. If a nurse has a question, please support her. Right? Maybe this and maybe some suggestions on the back end. Right? So had you seen this or this, maybe, and got some help, you know what I mean? And not try to fault people. Oftentimes they're taking on 8 patients. You think I can see everything? When I have 8 people, I can't. I'm human. Absolutely. I'm human.
Yeah, I've definitely seen it. So I used to work in acute care for 7 years before I worked in ICU, and
what does that mean when you say acute care?
Oh, like 4 to 5 patients.
Oh, yeah.
As opposed to 1 to 2. Like med surge. It was I did travel, so, a bunch of different places. But like, there was a stigma on calling the rapids because, like, the team would be like, why didn't you talk to us first or something? And it's like, if you did, it's like, I mean, I did, but... And then that, that causes some, like, moral distress for the nurse. Yes. Like, should I do something? That's why I think there's, in the EMR now, they kind of, like, took that, like, blame away. Like, for sepsis situations, it's like, okay, they meet criteria, so automatically MET was called. Sorry about it,
Good.
So that kind of, like, rids you of, like, that. But, that's...
What we do to one another sometimes is just, and I don't encourage that early on, but once you become seasoned and stuff, stop. We're all trying to do the best that we can. We all bring different stuff to the table, trying to meet someone where they're at and try to support them. There are going to be nurses, especially right now. You know that there are nurses that have never touched a patient. And because the governor overturned all that in every single state, there was law that was overturned that they didn't have to meet the 50% in-person clinical for obvious reasons. Or no one would have graduated in any discipline, right? That's not just our nurses, it's every discipline. So there are literally nurses, all they did was SIMS. Like, is there education and is there an organization that supports SIMS? Yes, I've recently came on my purview. This is a great way to learn, but it doesn't take the place of that in conjunction with touching someone.
Yeah. Yeah. Are there situations, do you think, that is there such a thing as overcharting? Yes. Should we, and what does that look like as opposed to, dotting your T's, dotting your I's, crossing your T's? What's the difference there?
Sure. When nurses feel like they have to write out this huge note and it's like the assessment's unchanged. Like, why do you feel like you need to, or copy and paste it? So you did something fraudulently, copying and pasting, to say when you could have said documentation still. I mean, assessment unchanged. You are allowed to say that. There's nothing wrong with that. And then I'll see there's a clear, like you talked about, there's a clear deviation, but that's not what you said in the care plan or you said something different than what you're charting. Or why are you going to make a note about something when maybe there wasn't even a deviation, or your check boxes are okay, right? There wasn't a deviation. Like you selected once. Is someone being on an oxygen a deviation from a lung assessment or respiratory assessment? It is. you don't got to document it 12 times. You
Yeah.
addressed it once. She's O2 dependent at home. You know what you're not fixing? Her COPD. So no one expects you to be weaning this off. Right now, it's a pneumonia patient or whatever. You're supposed to be weaning that off. You know what I mean? You see how that's different?
Yeah.
But stop documenting stuff or not addressing stuff. Like, no one is expecting you to get the COPD or off the oxygen. So stop with that.
I was thinking about specifically, like there's a smart phrase that you can use in your care plan called like the end of shift summary. And it's blank essentially. So you can write a little blurb about what happened, during your shift. And, in having this conversation, I'm like, is that double charting? Because like, that's, I charted in the flow sheets what happened during the day. If the chart doesn't belong to me and it doesn't belong to the docs, like then I'm just giving this little synopsis that's, digestible for whoever,
Right.
as opposed to like what's in the chart, cause I like to write one because it does, because like I said, the care plan, nobody reads.
Right.
Because it's just like ridiculous documentation. But, the summary is a digestible piece of like what happened in the shift that the docs may or may not read. But I'm wondering like, should I even be like writing that? Or if I do choose to write it, do I need to be more intentional about what I'm writing?
Well, so I would first and foremost, if the hospital policy says that you're supposed to be writing an end of shift note, which I've seen before, then you got to write an end of shift note.
Yeah.
Try to follow that structure. But let's just say there is no policy and your shift was, you're in an intensive care unit. Now, was I going up and down on the pressers? Was I doing all this stuff? And I just want to summarize it in a package because that's what I'm handing off. And I'm saying like, that's is what I let the other nurse know. You got 2 more runners that you got to go, whatever it is that I'm doing. We're, in the weaning process, the last gas was this. As part of your handoff so that, this is what I told the nurse basically in the handoff was, so there's no mystery. Now in a med surge unit, or in some of these other units, is that always going to be feasible? It may not be, right? And again, what is the requirement of your unit? And if you're checkboxing stuff and your nursing notes have reflected that, are you double charting? Are you, you know what I mean? But the patient had a fall and now you're tying this up in a bow. You checked on them, all this stuff. I would be writing a note, but you do have to be careful when it's, especially when it's something that's possibly, this is a litigious society. You're just supposed to be keeping it to the facts. It's a form of communication between the providers. You call the provider, create a note. Something happens, write a note. You do an assessment, write a note. And you can like group some of these things together as well that we oftentimes forget about, like some of the stuff that just seems little, but, reposition the patient and group these things together, water, whatever it is that you did, and then make one little, brief note or a smart phrase like you reference. If you do the same thing every single time, because you know what that looks like on the big screen, prudency. And you did it. You did it, right? You did it. And you can create some of these smart phrases because if you're doing the same thing all the time, you and I both know that you do.
Yeah.
Then give yourself some credit for that. There's nothing wrong with using that and tailoring it to what you're doing, but you're not copying it and pasting it from another patient from a chart.
Sure,
you see
sure.
what I mean?
What are some really helpful smart phrases and like what are some that you're like, don't write that in your, like we talked about non-compliance, like what are some phrases? Yeah. Like that. Like what are some that you're like, don't do that. Or like, this is what you should write instead.
So that you're continuing to monitoring. Really tell me about it. What is it? Clue us in here. Sometimes it's going to be obvious, but why do you feel like you're monitoring what? Now, if you're monitoring the patient's blood pressure because they got 2 beta blockers and their pressure was 100, I'm watching their map. I love it. Monitoring the map, got an order from the doctor, whatever it is. But, you don't have to write that 12 times, though. We know you told me once you got the order and that you're continuing to monitor. I can see you wrote some vital signs. They're staying within that. I think it's great. You held 1 blood pressure medication because you called the doctor again. I think that's great. But stop writing, continue to monitoring. What are you monitoring?
Yeah, like be specific.
Like I told the doctor. That was it?
Yeah.
And
MD notified.
I mean, and the patient's like, struggling to breathe, or that's not how it works. That's not how it works for us. You got to call, you already talked about that. You got to call the rapid. You got to
You got to
do
escalate.
whatever that needs. Yes. And then that's where your Nurse Practice Act comes into effect as well. And they will smack you with that. And
that's a really good point, because I think that people normally, when they write MD notify, they think like, okay, I did my part, but that's not, if you're still concerned about the patient, then, and they are in a potentially, decompensating situation. You have to like continue, you have to go up the chain and document that you did that.
Right. You have a duty to the patient. That's the loaded word they will use against you. And I can tell you my state, 1514, and I'm going to quote to you, this was passed in 1983, says that I have a duty to the patient that supersedes a hospital policy or a physician order. That was a nurse working in an emergency room setting in the 80s. So we're not like, there's not like all this STEMI stuff, right? That's not a thing. Right, the first stent is placed in the late 70s, 80s. So this is a new discipline. Patient comes in, small ER, Texas. Doc's like, nah, send him down the road, sister. She sends him down the road. Well, you know what happens, right? This is a heart attack. Dies. There's litigation. They try to report the board to the board of nursing, saying no, she was following the doctor's order. Texas Board of Nursing said that's fine. We're now putting a position statement in place in 1983 that says that you have a duty to the patient that supersedes the hospital policy of the physician order. You do not work for the hospital. You do not work for the physician. I tell nurses all the time, some of the stuff I talk about is not necessarily right, but you do not work for that organization. Your duty supersedes all of it. We are their last defense. And now it's you. And now it's you. Who would you want you to stand up or protect you? Who do you know whose duty it is? The person standing right there, that's the nurse's duty. That's the integrity of our profession.
Yeah. Yeah, that's loaded, because, if there's an order in there that you don't agree with, you need to stand up and talk about that and make sure, because that will be on your license is on the line. You can't say like, I was just following orders,
Not as the RN.
Not a thing.
Not as the LPN. If you're an MA, if you're a respiratory therapist, if you're a radiology technologist, you fall under the medical board and you are really an extension of the doctor. Nurses, RNs, we are unsupervised. LPNs have to be supervised, but we have our own independent license, independent of physician. So our boards even recognize that. And again, some of the stuff I didn't know all this stuff before I was at the board, but the stuff that I've seen over the last decade that they will use against you, and they do take it very serious. The board has a duty to protect the public, right? Their mission is not us. And I don't think a lot of nurses realize that, or the severity of that, whether you fall under HHS, DHS, ALJ, governor, you have a traditional structure as a board of nursing, their duty is to the public and not to us.
Mm-hmm. All right. I want to go over some, like scenarios, some of those situations that, proved time and time again to be, like you said, pressure ulcers, falls, like the most common litigation things, and like how we should document for these scenarios. So like, let's say your patient fell. Let's say, they like, how should you be documenting? Obviously, like, depending on the facility, you're probably going to have to write some quality report, some, quality initiative, whatever they call them.
Like an incident report or a MITRE.
Yeah, incident report. And then you also have to write a note, like, in the chart.
Correct.
Mostly. So what things do you need to make sure that you have in that documentation?
Well, you need to make sure that as the nurse that you've, assessed the patient, and that you're calling a rapid, you're calling a code, and that you're following the policy. You're getting that patient to essentially a higher level of care, or someone else looking, because there are going to be various settings that this could happen. You're in a long-term care facility, you're calling 911 because that patient needs what? A higher level of care. Can an LPN triage? No. Right? Can an RN triage in that setting? Right? They can do an assessment and call the provider, but more often than not, it's going to be a requirement to get to a higher level of care. Yeah. And then you have to make sure that you're assessing what's happening, what the extremity, we got an arm, we got a leg, we hit our head. Was there any loss of consciousness? Is the patient on blood thinners? Because again, when you're giving your SBAR communication to the provider, those are things that you need to know as the nurse that you're giving in your SBAR. So situation, background, assessment, recommendation. Patients on Xarelto, sir, got it this morning, or Lovenox, or heparin, ma'am, and then you're doing your assessment of neurovascular pain, all of it, and following the policy. And if they continue to have pain, then they have to be reassessed. Then what's happening? You know what I mean? What's going on? So you have to make sure that if they continue to complain of pain, you know, that the physician comes and assesses the patient, and that they get seen by a higher level of care so that the appropriate interventions, imaging, whatever needs to happen, happens. And then you're writing a note. You're writing a note in the medical record in just a factual manner. I came into the room, the patient was on the floor, was alert and oriented. You don't know if the patient had loss of consciousness, so you shouldn't write that. Did you, do you know? You don't. It was unwitnessed. And you need to say unwitnessed fall, patient found in room, whatever the words are. And then again, I hope that you had already written that side rails were up, that the call line was within reach, that all that stuff had already been documented. You can sure write that now, but do you see how that, you know what I mean? If you're writing it after the fact, you see how that may look. So making sure that you're being diligent and, like you said, intentional with your charting, because I know you were doing all that stuff. I know you saw the side rails were up, you checked them, you made sure, but you didn't give yourself credit for it.
Yeah.
You said you came into the room because the bed alarm came off, but no one knew that because you didn't document it.
Yeah.
Right?
When you document later, like if you're back charting, but you're charting for the first time, can you still pull up at what time something was charted?
Yeah.
So let's say it's 4 p.m. and your patient, and you haven't done your assessment yet. Like you haven't charted your assessment. So you're charting at 4 p.m. That you can see what time
that you logged in
the 8 a.m. assessment.
Yes. It's again, the common sense argument. No nurse expert, again, if they are, they're totally lying, can get on the stand and say, they should have charted at this time. No, because again, if you show, there was 3 codes. I am required to do the care first. Right. I mean, so the standard is not the best practice is real-time documentation. The patient's on the ground. You're not doing real-time documentation. It's not feasible. So you can come in the time that you did the assessment or the care, you can document that, but you can't be in 2 rooms at one time. You cannot check the restraints at 8 a.m. on both patients, because now that is up on the big screen. So tell us, oh, really, Maggie, you're that magical. So you were in room 3 and 4 at the same time. I'm just checking your documentation. And now you're inviting them to troll all your records. So this looks like a pattern, right? It looks like you do this every single day. You fraudulently document, right? They'll ask you a fraudulent document. They'll make sure you know what that means before they ask you the question. So they'll make sure you know, right? Because the first 5 minutes they're going to ask you, so do you know what of course I know what fraudulent is. Can you delete documentation? They're going to take you down this road. Then they're going to ask you about what you did. Yeah. And then you can't say no. Yeah. Right? They've already established the standard.
Charting in real time, so important. And I mean, I appreciate that, that understanding that care comes first. And if you need to chart earlier in the shift, it's just, part of it. But it doesn't look good if you are charting a fall at 4 p.m. and then you start charting your shift assessment, at 4:30, because then you're obviously, in retrospect, making sure that everything is, looks perfect.
And it's all about optics. And I'm not telling you it's right? Because it's theater, right? You may be you did it. You do it every single day. And that's what will be your defense. Look at my other charts, right? I was busy. I was talking about this and in my normal practice. And that's the language you have to be comfortable saying. But you're not an expert, right? This is not what you do, right? Those words are not going to come to you easily. And nurses oftentimes feel very uncomfortable with all that stuff, as they should, because we're the caretakers, right? We're not trying to worry about, our defense, right? We're literally struggling just to take care of patients. Yeah. Right. And then you get called up. Hey, come on down. Just a deposition. Maggie, don't worry about it. Next week. And you're like, wait, what? Yeah. What do you mean? And then nurses don't realize as well that you have rights like that. Don't call me down in my shift. No, no, Lawyer Smith. Absolutely not, buddy. when I'm not taking care of patients, I'm more than happy to come in and look at some case that you're saying that I'm involved with litigation. I'm more than happy to do that on my time, and I am clocking in. And if they're asking you to open up a medical record, just tell me the petition number, Lawyer Smith, while I make a note in the medical record, because why am I in this medical record? You're still bound to HIPAA. You can say I'm looking at the medical record for a deposition. But okay. I say that, and this is the petition number. But do not, and that's on my schedule. And you're not deposing me until I'm comfortable. No, this isn't contingent on me, buddy. No, you got 12 other people you could depose. Stop, move on. I'll let you know when I'm ready. When I review the case and I have been involved 3 years into my career. There was a pressure ulcer case, and I was in an ICU. And 5 minutes, sister. One of my other friends, she unfortunately lost her license. It became ridiculous because it crosses over into several courts of law because she's found negligent and I not rightfully so. Couldn't get the patient on the bed quick enough. We're at Lackland in the trauma ICU during Desert Storm. No one's coming on to a level 1 trauma base and not getting clearance. It's the middle of the night. Do you think she could get her on one of these high dollar beds? Patient had femoral access, CRT, all the stuff, grossly unstable. I was writing, this is paper charting. This is 03. I'm writing all the words, can't turn, the percentage of air, I'm shifting hips, I'm documenting all of this stuff because I'm doing it. And this is paper charting. 5 minutes. And they're like, okay, bye. Thanks. I moved along. And then she ended up not keeping her address up to date with the Board of Nursing. Her husband was active duty. She moved to another state. They found her negligent in the civil case. The Board of Nursing tried to reach out to her. More often than not, that's 3 times. They'll send you a certified letter to your required up-to-date address that's supposed to be changed within 15 to 30 days that most nurses don't know about, but I digress. And they sent her letters. They came on back, and then so they revoked her license. She goes to renew her other license, and they're like, no, sister, you don't get to hold on to another license. There's no double jeopardy for us. You will, all those license fall. You will stand in front of every single board that you hold a professional license in. And that was a revocation of her license. So that's 5 years. She couldn't come back to the table for 5 years, and I just helped her get her license renewed again. So I helped her at year 5, and then I just helped her renew again. But do you see how one big animal? And if you don't think that your documentation is a big deal, if that's not one example, I don't know what else would be. I'm a lot and I'm animated, but it's for that, because those are the nurses that reach out to me, right? And then I look at your documentation and there's nothing written, and I'm like, oh my gosh, you can say your normal, and again, how is the expert even supposed to pull together anything? You wrote nothing. What is that expert supposed to use to help defend you? You've given her nothing. You wrote nothing.
Yeah. When you do, if you ever do get that, letter that you're being deposed, what steps, can people call, somebody like you, or what, do they get a lawyer after that, and walk them through the steps? Where do you go from there?
Yeah, it's a great question. So not that I'm trying to plug myself, but
plug yourself. We're almost at the end of the episode. This is where to do it anyway.
So I won't help. I'm a nurse. I'm being deposed because civil litigation, this is very different from the Board of Nursing. I already told you within the first 5 to 7 minutes, they're going to be asking you who prepped you or you're not saying me. No, not a lawyer. But you do need to know some words. So in the book, it's like, what is a plaintiff? What's a defendant? What is a petition? What are my rights? Because nurses all want to just start singing and telling them, and I'm like, what are you doing? Stop it. Stop. Where I was in the break, or 11:30, where are you at? I had given salary report, and it's not what you were asked. Where were you at? I was in the break room. Okay, so did you give a report to someone? I did. Make them pull this out of you. So that's civil litigation. So I wrote that book because, again, we don't understand that language. We don't understand our rights. We don't understand what that means. This is like 20 pages that dumbs down some stuff, what to wear, some simple things, because that's civil litigation. And if you get found negligent, you do have to report that to the Board of Nursing, which is very different. You can go to a deposition in front of a Board of Nursing as well, but different, right? Your conduct is being questioned. Not always call it a deposition, but sometimes nurses will use that language. If you do stand under like an ALJ, and I don't want to get into too many weeds, it may be like a true deposition. And the last place that you want to be is a trial lawyer questioning you. Right. So this is like California Board of Nursing. It's an ALJ. This is a trial lawyer that will rip you up. So great question. But you can go to the risk management. That's where you go. Like, what does this mean? You know what I mean? And just ask them. Call some medical malpractice lawyers. Get your free 15, 30 minutes. This is what's happening. I was the primary nurse. What are your thoughts? Get legal representation. I mean, they're going to tell you, did the patient have a bad outcome? Did they lose their limb? Did they lose their life? So at that point, some logical things should start clicking off in your head. The organization, that lawyer's check is being cut by Sunnyvale Hospital, and I was the one that caused the death. So I probably want to reach out to a civil lawyer before I sit down with the hospital or you can sit down with the lawyer with the hospital, whatever, and it's going to come. Most of us have a common sense. It's going to come to fruition, and that's private. That's confidential. You're not being deposed at that time. So you can say, I want to look at the medical records. They start talking to you, and you're like, oh gosh, I'm looking like I may have been negligent here as I start to look at this. And you're like, so I think I'm going to get legal counsel. I think it might be in my best interest. So let's put that deposition on pause, and I'm going to seek out some legal counsel, and I'll get back with you. But I think it's in my best interest to speak to someone else. You're not. Sure. This isn't like you're not charged with a crime. They can't make you come to the deposition. I mean, they're subpoenaing you. That's not true, but it can be pushed back on your schedule. You are allowed legal representation.
Okay, gotcha. Yeah, I know that you also have an online course, correct? Because I get the emails. So tell me about what some of the educational opportunities, the events, anything that you're promoting right now.
So the charting course is like the biggest thing that nurses have been asking me for, because again, they always ask me, how do I chart? So you get a CE, it's an hour. And then I think the handout's up to 16 pages because I take feedback. So, because again, I want to, you know what I mean? You're coming to me. I'm more than happy because I'm not the end all to be all. I may not know, but let me get that for you. Or so it has like some cases in it. It'll have like, this was the case, this was the standard, and this was the breach. And then I have things like the SOAPy or the definition of medical malpractice. I read it to you in the presentation, but I don't want you to write it down. I give it to you in the handout because I want you to pay attention to what I'm saying. I don't want you to scribble down a bunch of words. Yeah. So I teach nurses that, and then I have a legal nurse course. I teach nurses how to cross over to legal nursing. Nurses have this misconception like they have to spend thousands and thousands of dollars on courses. You don't. I don't have a certification. I let the Board of Nursing, I didn't know at the time, teach me how to become an investigator, which crossed me over to be a civil expert. And then I started teaching myself some of this stuff because you're not a lawyer. We're not trained. You know what they want? Your nursing knowledge. They want you to look at the case. And if you don't know how to write a report, then they could have legal nurse consultants already there. Why are you inventing the wheel? Let them teach you. Or if you're the expert, you know what I mean? Lawyer, send me over the last 3 expert reports that you liked. Why do you care? You have the knowledge. You just need how to write it, learn how to write it in that manner. And there's like 100 things that a nurse can do as a legal nurse. It's not a testifying expert and or a consultant. There's so many other things that nurses have no idea that they could cross over into. And that's like the first 30 minutes of the course. And then I teach how to set up a business because you can't take money as Maggie. You have to take money as advocate Maggie because you don't want to be sued, right? It's the same thing with malpractice. Yeah. So I'm doing like a blog. I try to get information out there. If I'm asked on a platform, then I try to create something in a blog to get more information where I spell it out. I give you a regulation. So my whole biggest platform is this, trying to educate nurses to keep you from standing in front of one of these 3 courts of law. Yeah. So,
yeah. Well, it's such a necessary. Thank you for doing what you're doing. I mean, it's information that I never knew and people don't think about, and it's so necessary, but people don't think about it until they're in that situation. So
I call them the one percenters. Unfortunately, I've coined this word, and I'm like, it's not till it's the one percenters. Because even in my own place of employment, I'm not at the bedside anymore. I was shamed and told I'm being animated and activated. And then they would see nurses come to me. Like a nurse came to me because she got reported to the board of nursing for shocking a patient that was in VT. Let me say that again, saying she didn't have an order. And she had no expert to defend her in front of the board of nursing. That's not defendable, right? Again, why would she ever sign those orders? But she didn't understand what that meant, and you know what I mean? And just sign away, like, because the nurses, she was standing next to her, retaliating against her. Had I, myself and, her legal team, if she had a legal team looked at that, you know what I mean? I could have been the expert for that and wrote saying that, no, that falls under the ACLS protocol. It's actually mandatory. That patient lived.
Yeah. That's wild. Well, Maggie, thank you so much for coming on and talking with us today. And your website is advocatesfornurses.com, correct? Yeah. So if you want any more information too. And your book is, remind me of the title of the book.
Help, I'm a nurse, I'm being deposed.
Yes. Yeah.
Not being good. So different than board of nursing litigation, right? So nurses, because it's a different, you're considered guilty in front of the board of nursing. You have to prove your innocence, unlike civil criminal. So nurses, that's why it's so important that you understand the rules and regulations that dictate your license, please.
Yes, absolutely. All right, Maggie, it was great talking to you. Thank you so much for coming on. We'll talk to you soon.
Absolutely, be well.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.